Welcome to episode 9 of the Pro PA podcast. I'm your host, Prof G, and today we're covering influenza, another high yield topic in our pulmonary infectious disorders series straight from the PANCE blueprint. Whether you're preparing for exams or tackling flu season in the clinic, we've got you covered. Okay, so let's start with the kinder patho. What is influenza? So everybody's heard of the flu. We hear about flu season every single year. But what exactly is the flu? So, influenza is an acute respiratory illness caused by the influenza virus. And it's typically classified into three kind of subtypes. We have influenza A, which is the most severe and usually the one responsible for pandemics. We have influenza B, which causes kind of seasonal outbreaks, and it's typically a little less severe than influenza A. And then we even have an influenza C, which can cause mild illness, but it's rarely significant. And most of our tests that we do for flu don't even include influenza C. So that's kind of how rare it is. Now, this virus targets the respiratory epithelium, and this leads to cell death and it triggers an intense immune response within our bodies. Now, the spread of the virus happens via respiratory droplets, which are like coughing and sneezing, and it can also be transmitted by direct contact with contaminated surfaces. So, one key patho pearl that I actually just learned while doing the research for this podcast is that influenza A can actually undergo an antigenic drift, which are kind of small mutations from season to season. And that leads to the seasonal flu changes and the updates in vaccines that we have every year. But it can also have an antigenic shift, which are major changes within the viral structure. And this is what causes the pandemics that we see, like the 2009 H1N1 outbreak. And I thought that was really interesting because as a PA in the emergency department, I was on the front lines during that 2009 outbreak. And I'll tell you, the ER waiting rooms were pandemonium during that period of time. All of the parents and patients were all worried because this particular strain of flu was causing pretty severe reactions in seemingly healthy patients. So I thought that was really interesting. Now, who does the flu affect? Well, everyone. Everyone is at risk, but there are some high-risk populations to consider, including kiddos, so under the age of 5, and adults over the age of 65. Those are kind of who we worry about the most. Other people that we worry about are pregnant individuals and immunocompromised patients, and those that suffer from chronic diseases like COPD, asthma, and diabetes. Now, the flu, as we know, is seasonal, right? We see flu cases peak in the fall and winter months, usually between October and March in the United States. And that's why we try to get patients vaccinated before the flu season starts. So, how do these patients present clinically? Well, the classic symptoms is abrupt onset, boom, feel like you just got hit by a truck. And that is accompanied by fever. It's usually pretty high fever and chills. Another hallmark feature is this myalgias, these intense muscle or joint aches in the back, in the legs, in your joints, and a headache. Patients also get kind of upper respiratory symptoms, including cough, which is typically non-productive, sore throat, nasal congestion, runny nose, and they have a lot of fatigue and malaise. On physical exam, it's usually pretty unremarkable aside from some mild tachycardia, maybe some visible pharyngitis. In more severe cases, sometimes we can hear or see signs of pneumonia, dehydration, or even respiratory distress. A little pearl about this is flu has a very sudden onset of symptoms like fever, myalgias, and this can help differentiate it from other upper respiratory infections, which are usually more gradual in onset. If a patient comes in saying, I was fine, I was at work, and boom, these symptoms just kind of started all of a sudden, think the flu. So, from a workup standpoint, the diagnosis is often clinical during flu season. You can see that there's lots of cases coming through your clinic or your urgent care emergency department, and you can kind of have a high suspicion. We do have some testing that we can do for the flu, including rapid influenza diagnostic tests, which are a little nasal swab that we can run. We have the results within 10 to 15 minutes. There's also an even better test, which is PCR testing, and this is actually the gold standard as far as accuracy is concerned. We can also consider doing chest x rays if we're concerned about complications like pneumonia. Now, management. So, supportive care is going to be the mainstay of treatment. Remember, we're going to advise rest, hydration, antipyretics, including Tylenol and ibuprofen, and this will help with the fever and the body aches. We also have a medication we can use, which are antivirals. Now, these antiviral medications are advised to be started within 48 hours of symptom onset. And the one that most of us know and use most often is Tamiflu or oseltamivir. This is the first line in most patients. We have a couple other options. We have zanamivir, which is an inhaled option. We have baloxavir, which is a single dose treatment. It's newer for uncomplicated flu, but for the most part, we stick with Tamiflu or oseltamivir. Now, in high risk patients, we want to start those antivirals regardless of the symptom duration. So, even if they come in 4 or 5 days after symptom onset, if we know it's the flu, we want to start them on the antiviral medication regardless. And this is because they're at increased risk of complications. Now, one really important thing to mention here is prevention of illness. Now, every year we have an annual influenza vaccine that is put out. Basically, they look at the previous year's strains and they kind of try to predict where the flu is headed for that next flu season. And so, this is the most effective prevention strategy for patients, and it's recommended for everyone 6 months and older. There's also some higher dose vaccines that are available for patients 65 plus, so that's something else to consider. We also need to encourage good hygiene practices like hand washing, covering coughs like in the elbow, and staying home when you're sick. As far as post exposure prophylaxis, you can consider oseltamivir for high risk close contacts. Now, complications. There are some complications that can arise from influenza. In most cases, it is a self limited viral infection, but you can develop these other complications, including pneumonia. So, look out for that secondary bacterial pneumonia. It's often caused by pathogens like strep pneumoniae or even Staph aureus. Some patients can even get a primary viral pneumonia, so look out for those extra symptoms of dyspnea or abnormal lung sounds on auscultation. Other things, acute respiratory distress syndrome, ARDS, it can cause this, especially in those higher risk individuals, so keep an eye out for that. You can also have an exacerbation of underlying conditions like COPD or CHF, so definitely pay a little closer attention if you have a patient with comorbidities. In very, very rare cases, you can also get myositis, myocarditis, or even encephalitis caused by the flu. So let's talk about book med versus street med. The book med's going to tell you start antivirals within 48 hours of symptom onset and supportive care otherwise. But on the street, with high risk patients and even normal risk patients, we tend to give Tamiflu, even if symptoms started more than 2 days prior. And another thing is, they say in the literature we don't have to necessarily test every single patient that comes in with flu like symptoms. But I've seen in the ER that I've worked at, we tend to test pretty much everyone that comes in with flu like symptoms so that we have a more definitive diagnosis of flu A, flu B, and have something to kind of hang our hat on. So, quick clinical pearls: sudden onset, fever, myalgias, fatigue equals influenza, especially during flu season. You want to start antivirals within 48 hours or later if the patient is high risk. And complications like pneumonia and ARDS are life threatening, so don't miss those. Okay, now that we've gone through this, let's do some quick review questions to kind of test our knowledge. Okay, we have a 70-year-old male with COPD who presents with sudden onset fever, myalgias, and non productive cough. He's tachycardic but not hypoxic. What is the best next step in management? Is it A, supportive care only, B, start oseltamivir, C, a chest x ray, or D, prescribe antibiotics? If you said B, start oseltamivir, you are correct. So high-risk patients like this elderly patient with COPD should receive antivirals for influenza, even if they're presenting within or beyond that 48-hour of symptom onset. Our next question is a 35-year-old previously healthy female who presents with fever, fatigue, myalgias, and a dry cough for 4 days. A rapid influenza test is positive. She's otherwise stable, has no risk factors or complications. What is the most appropriate management? Is it A, start oseltamivir, B, supportive care only, C, prescribe antibiotics, or D, order a chest x-ray? I'll give you a sec. If you said B, supportive care only, you are correct. Now remember, the vignette mentioned that she had these symptoms for 4 days, which is well over the 48-hour mark. And for low risk, healthy patients, symptom onset greater than 48 hours with a positive flu test, treatment is supportive care with hydration, rest, antipyretics. Antivirals provide limited benefit in this population beyond the early treatment window. Okay, and as always, I want to thank you for joining me on today's clinical medicine brief on influenza. Remember, the key to managing flu is recognizing the sudden onset of symptoms and starting antivirals early in high-risk patients. Prevention with the annual flu vaccine remains our best defense. For more high-yield pulmonary content, check out my pulmonary module on my YouTube channel, Professor G PAC. And if you enjoyed this episode, don't forget to follow and turn on notifications so you never miss a new episode. As always, this is the Pro PA podcast, where future pros in medicine are made. I'll see you in the next episode.